So there were three people, one nurse and a marketing guy and a statistician, and a simple question was asked, what is 2 plus 2? And as the nurse is, she is very disciplined, obedient, knows what needs to be said, what is tutored to be said. So she said 2 plus 2 is 4. There was this marketing guy who said 2 plus 2 is 22. And then there was this statistician who huffed and puffed and closed the door and said, what number do you want? Unfortunately, nursing is between these two great group of people who is always getting into the shortcuts, and there is a group of people who is always exaggerating. And this group of people who is so fantastically trained that they do this job superbly well. So this is generally how it happens. I am not sure why Bobby selected this particular topic. इंडिया नीड्स 1.37 मिलियन नर्सिंग स्टाफ. जब आपके पास नर्स ही नहीं है तो आप एंगेज किसके साथ करोगे? As soon as they are passing out, they look for a very good opportunity and they are all going abroad or for a better pasture. So the movement is so fast, and then who's going to engage? India needs close to 1,37,559 doctors. So neither there are this group of people who is available, nor nursing who is available. So unfortunately, we are in a very, very different mix. And that needs to be really sort of worked out. But if you actually see what would be the trend, it is soon changing. And what our Prime Minister keeps saying at 2047 at Viksit Bharat, possibly at that level will balance the supply and demand. But it's going to be tough. Next year, 1.5 lakh nursing staff in NIH, they are retiring. So most of you will not be seen in the next session at all, because all of you would be looking a job in Ireland and UK. So it's very, very tough. So whom to engage, it's a difficult question. Now, you have to engage with these stakeholders. So this is me, which is only looking at return of investment. The attitude is a problem, and if any hospital starts anything, we are good copycats as an administrator because we want to immediately copy. People like me suffer from attention deficit disorder, because if you send me a mail 4 paragraph, I cannot read it, and you send me a lot of raw data, I just cannot read. And we are okay with mediocrity, and then there is a first mover advantage. First in India, Southeast Asia, we start from there, and then there's a lot of programs. So unfortunately, you have to engage with them. But then the next group of engagement happens with this, who talks about, on a podium, they talk about evidence-based medicine, they don't practice. On a podium, they talk about team medicine, but they are culture of individuals. They're very disjointed communication, and there is a hierarchy, and there is a professor, and then there is a senior resident, and there is massive ragging in between. But then there are data-driven people and huge training which is required. We have another group of people who are very cultured, who talks about changing a lot of things, but unfortunately they just don't meet that requirement because they don't move out from there. Then this is this group who are very obedient, who are very hardworking, very emotional people. And when you go for NABH assessment and you see them, moment you ask what is vulnerable, pat karke answer aata hai. What is medication error, pat karke. They are so ready with everything, but then they are not there. They are moving out so fast. So how do we engage? There are other group of people who are incredibly trained. They need attention because job opportunities are very few. There are this group of people who, again, are sort of not available. So everybody wants to get into a digital mode, but it's a garbage in and a garbage out. And how do we basically work within this field, because real-time data, what we want to make some changes, is not available. And then there are these queen and kings who basically rule the world of healthcare. They are there in each floors, each medicine and surgical ward, but they are fewer in numbers. They work on an auto mode, and they just don't listen, and they are with you till the next NEET exam, and they are off. So basically, we are looking for this for an engagement which is behavioral change, and behavior just don't change because we are set in a very particular kind of a training mechanism which happens in a nursing college and a medical college. That doesn't change, and we are in a very chaotic. So how do we engage in a very chaotic healthcare where we are not looking at innovations and we are not looking at new variety? From my side, you are at the top because you run the hospitals. 70 to 80% of the healthcare is run by you. You provide what is the emotional care, you provide the sympathetic care, you provide the empathetic care, and rest are all there. But then you are the queen of healthcare, and that's important. I'll just run this. She is my wife. She's a professor of anesthesia. Unfortunately, she has always been a bad side of statistics. And what is written here, M, is not days, it is month. So she had a biliary sludge, ERCP was done, went from ampulla of Vater, went into the pancreatic duct, injected a dye, went into acute hemorrhagic and necrotizing pancreatitis. Month 1, pancreatitis. Month 2, subcolic abscess throughout the abdomen. Month 3, burst abdomens with multi-drug resistant organisms. Month 4, pericardial pleural effusion septic. Month 5 and month 6. So fortunately, she is alive. There were 16 patients who were admitted next to her ICU with post-ERCP pancreatitis. All of them passed away. But God was kind and she was there. So it was a hospitalization for 6 months with a bill of close to 1.2 CR. So did we do a risk assessment? So, but we went through a very depressive phase during this time. What we remember very fondly is the nursing care because she doesn't have a peripheral line during this. It was all genostomy or from central line. The right IJV is also blocked. Only left is available. Femoral you don't try. The nurse used to spend 4 hours looking for each small vein because some intravascular fluid has to go in for her to survive. The nurse used to spend 2 hours just combing her hair and talking to her. She was bedridden, cannot just move, and having a fever of 105 every day. It was a pan drug resistant, nothing was working. They used to get a wheelchair and take her out for some sunshine and take her back. And that is what you are. And that is what I'm saying. You are top. You are one of the best healthcare professionals which anybody can witness. And you are doing a fantastic job. Can we engage? And is there a mechanism of engaging? Expertise phenomenal, but unfortunately it is not matching with the expertise of clinical people because if you look at a pediatric cardiologist, he does his MBBS, he does his MD, he does his DM, moves out to Boston Children's Hospital, he learns there and comes back and works with a GNM and a BSc nurse. The demand, the disparity is so huge, and that is where the discordant happens, and that is where the clinicians has to work because you also have to basically get to that expertise, and that is where engaging will happen. So there's a lot of work which we have to do. There has to be a trust factor which is very important, and you gain trust very easily because by nature, by training, you are very empathetic soul. Transparency right now doesn't happen, and unfortunately we also see lots of ethics in our documentation which happens on a day-to-day basis. So there is a lot of improvement which has to happen, but then implementation of the feedback. If you go to the topmost, I cannot say nursing director, but if you are sometimes cajoled, sometimes blasted, because unfortunately you are under a lot of pressure from the medical. So the transparency feedback, which you develop so very well, unfortunately that whole fabric gets destroyed by clinicians and people like me. So that needs to happen. But in our setting, did we try engaging? So most of my good decisions, which has happened to improve operational efficiency, all comes from nursing, and the whole credit of doing good goes to nursing. So if we have a good line infections, putting a Q site, if you have putting a Ganji pads, If you see that they have been doing medication error, putting all syringes on the bed, they identify and they correct. We don't do anything. They are empowered and they are engaged and they suggest, and most of the improvements comes from them. Rest of them are only taking credits. There is a checklist which is always filled. Yes, there is a huge scope of improvement, but then if there are silent observers and educators, they are going to do a fantastic job. Plus, most of the SOPs, they are so tuned to NABH now that most of the SOPs are also formulated by you. So you all do fantastic work, and all the operational efficiencies, all the leadership, strategic management, operational management comes from you, and we should give that credit. Sorry, there is a surgical site safety checklist. And who all practice surgical site safety checklist in the hospital? That's all. Everybody. So everybody practices, and this is Atul Gavande who basically brought this surgical safety checklist. But what is important is we are only doing it as a documentation. We are not doing it for reduction in mortality, morbidity, for the very need that safety checklist was ordered. And that change has to happen in nursing. So we have to move from just documentation, get into an ethics of documentation and the fatigue of documentation. One good work which we initiated was putting an ethnography and using a tool called sociogram. Unfortunately, medicine, both nursing and medicine, is very hierarchical. The senior surgeon speaks and nobody else talks to the bystander and the patients. And that happens even in nursing, and that has to change. So the behavioral or the practice and engaging will only happen if that hierarchy is changed. A lot of mentoring needs to happen within impact and value-based activity. There's neurosciences of leadership, because it's not because of right now we become senior by hierarchy, but it needs to be, your potential has to be identified. And there are lots of senior nursing staff who are also managing the hospitals. So you are at the top, you're doing fantastic work, you're all engaged. My plea would be that start working with the clinical team, and clinical team should definitely recognize, and all the stakeholders should come forward. But then you're at the top, you're doing fantastic work, and keep doing. Because of you, all hospitals shine, and because of you, the patient goes back very healthy and happy. So thank you so much. Thank you for this.
Sir, I request you.